Hello and welcome to the Alabama Public Health Training Network. We've all been in a situation where a patient or a family member acted inappropriately in the clinic or the home setting, and we all know how uncomfortable that can be. Any type of agitation in an acute behavioral emergency and requires the immediate intervention. Traditional methods have been replaced with a much greater emphasis on a non-coercive approach. Today we will discuss interventions to help successfully de-escalate patients and clients with disruptive behaviors. Thank you for joining us for today's program. De-escalating consumer behaviors in traditional and non-traditional healthcare settings. If you have a question about anything being discussed today, please call or email during the broadcast. The phone number and email address are on the screen now and will appear later in the program. Also, the handouts, sign-in sheets, and evaluations are all available online. You will need to register for this program in order to access these materials. Continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program and then complete and return the sign-in sheet and evaluations. While the content may continue to be relevant, CE credit will only be awarded for 1 year for nurses and will expire on March 31st, 2016, 2 years for social workers expiring on March 31st, 2017. I'm Jacqueline Giddens. I'm a nurse with the Bureau of Home and Community Services, and joining me today is Renee Carpenter, the State Social Work Director, and our guest speaker, Ms. Ava Gregory, Director of CUSA Community Services. And welcome, everyone. Our objectives for the program today that we're going to be covering are to explain the ground rules and how to set appropriate boundaries with patients and clients. We're going to identify different communication styles when working with aggressive personalities in both the private and professional settings. We're going to discuss interpersonal skills that are needed when providing services to disruptive groups. And we're going to address different types of behaviors that require de-escalation in the clinics, social service agencies, and a disaster setting. And now I will turn the program over to Miss Ava.
Thank you so much. We're going to discuss a little bit of what can make a person disruptive. Of course, fear is they're wondering what's going to happen to them. Feeling ignored, being sick, being exhausted, feeling out of control, or just being angry. And in the elderly, a bad behavior, one of the number ones is rage, anger, and yelling. The age and illness can intensify the long-standing personality traits in some very unpleasant ways. Somebody that can be very meek and mild could suddenly become very angry, very sometimes inappropriate. An irritable person may become enraged. An impatient person may be demanding and impossible to please. Unfortunately, the person taking care of the elderly patient is often the target. It's usually the person closest to them. What we need to do in that situation is to try to identify the cause of the anger. In most elderly individuals, behaviors are a symptom of distress. Another thing we need to do, the aging process of itself sometimes brings about the anger. As seniors vent frustration about getting old, having chronic pain, losing friends, having memory losses, and being incontinent. I've seen a lot of elderly people sit there with the newspapers as their friends are dying, looking at the obituary columns. All of these unidentified things that can happen to us as we age. In addition, Alzheimer's diseases and dementia can also cause these behaviors, and in these cases, the patient does not have control. Dementia in itself is a process of loss of mental function due to a certain disease that affects the brain. The losses are substantial. Over time, all types of dementia will lead to the loss of memory, loss of reasoning, loss of judgment, personality and behavior changes, and physical decline, and eventually death. Dementia is not only hard for the patient, it's very hard for the family, and those caring for it. It's heartbreaking. It really is. By the course of dementia can take a vary widely from one person to another. It may not affect your parent the same way it does someone else's. It's influenced by many factors, including the age and other conditions a person may have. Sometimes a UTI or different things can bring it on a lot more intense than other times. 60 to 80% of U.S. dementia cases are caused by Alzheimer's disease. That's about 5.3 million people. The most common dementias are vascular dementias or tiny strokes in the brain, and the Lewy body dementia are alpha and protein lodges in certain regions of the brain.
Ava, I wanted to ask you, you've talked a lot about the dementia patient, which
yes, ma'am.
We all know that they can have a lot of changes. And
absolutely.
as you mentioned, as a nurse, I'm very well aware that something as simple as a urinary tract infection can really throw them completely off.
It can.
It truly can. And even being a little bit malnourished, or particularly if they're not getting enough hydration, which is quite frequently seen, that can definitely alter their behavior or their response. There's also a lot of problems I know that we've seen in home care, as well as probably the clinic setting. And Renee, you may have seen some examples of patients that are not necessarily elderly, or maybe it's the patient's caregiver, like you said. With the dementia patient, they're particularly under a lot of stress. But we see various ages of clients, both in the home and the clinic setting. But I'm sure you've seen that escalate as well.
Absolutely. And with someone, an elderly patient, sometimes they get to be a little bit picky eater, picky drinker. And as we know, water is what hydrates us. Sometimes they stop liking water, they want to drink Cokes or other kind of sodas a lot. And that leads to dehydration. Sometimes they forget to drink. So, you know, hooking them up with an IV with a little bit of fluids really does help that situation.
So maybe a short-term visit to
absolutely.
the clinic or something, to get the hospital to get a little fluids or something.
Absolutely, and the family also needs support because they're feeling so overwhelmed. And that person that raised them really doesn't feel like they're there anymore because they're looking at the person and their personality may have totally changed.
Now, what do you see with patients that are not elderly or not necessarily a diagnosis of dementia? Anything general that you can share about that?
I think particularly like a traumatic brain injury.
Traumatic brain injury, absolutely. That can be very difficult. And again, the family's not seeing the person they used to know. So that's very hard on them, especially when we have our young people coming back after a car wreck or a military situation. And they're heartbroken because they want that person they used to have back. And, you know, the person can be enraged one minute. They can be very scared. And it's heartbreaking to the family to see them go through these things.
I know you've got some scenarios that you were going to cover with us. If you would, you can go ahead and read those, and then Renee and I thought we would discuss them.
Okay, sounds great. Okay, scenario number 1. You've been called to the home of an elderly patient or client. The patient is a 75-year-old woman that has always been very polite and cordial in the past. Today things are different. The woman is screaming that her daughter has tried to kill her, and the mother and daughter have always been extremely close.
Unfortunately, this is a lot more common than a lot of people may think.
I know that it says here, too, that the woman wanted to call the police and insisted that her daughter be arrested. The daughter was upset and crying hysterically, So what would we do, Renee? What would we do as a nurse and then social work represented here?
Well, it would be great if we were out there together.
It would be great.
Because one of the first things we need to do is separate the two.
Absolutely.
Probably their anger is feeding off each other. So trying to separate the two, I think, would be primarily the first step. Secondly, I would look for a medical cause.
Yeah, that I would think in terms of the same thing. You want to have a multidisciplinary approach if at all possible. You need somebody, if you're, typically there's not going to be us two out there making a visit together, but you'd want to get someone to help you so that you could separate the client, the patient, and then the daughter, so that you could kind of calm down the situation and then begin to assess both of, whoever's helping you. You might want to have the clinical person, the nurse, assess that patient. That's what I'd be thinking. What is different? All of a sudden she's acting this way. Are vital signs okay? Is she having some TIA, some little mini strokes? What's really going on there? So that we can start figuring out what's going on. She's already called the police. They're probably there. It may be that we have to get that patient, go ahead and call EMS and get them to the hospital, get them assessed clinically, and then whoever's with the daughter, reassure the daughter that, we're going to get to the bottom medically, that there's probably something going on acute, since that had not been her normal behavior. Be a little different than someone who had dementia and had been progressing towards this. So
Absolutely.
That was our thoughts.
Well, a lot of times in these situations too, what the patient is assuming is that the medications they took were the wrong medications, or that they're being poisoned. That's a very frequent thing to hear. So I would think it would be fairly easy to get her to an emergency room for a medical evaluation.
I would
by
think
simply
so.
saying, we need to find out what you may have been given. We need to find out, have you been poisoned or whatever. So that way we could get her medically evaluated pretty easily. I'd also call in some family support. This is a good time to bring in other children or friends even, somebody that the patient and the caregiver are both very familiar with and trust, because they can help settle the situation down too.
That sounds like a good idea.
Awesome.
Those were our thoughts, Ava. You're the expert. So,
Well, the thing is, I would definitely try to reassure the caregiver as well, because this is traumatic for them. They've always been very close, so absolutely, like y'all said, reassure the caregiver that, it's okay. Things are going to be all right. You're not in any kind of trouble. And absolutely also reassure the patient, because they're scared, or they wouldn't be kind of making these kind of threats. They're very scared. This is a root of fear.
and then the second one.
You're trying to do an in-home evaluation, and the patient is mumbling and talking to themselves. The patient is not well groomed, and this is very unusual for this patient. What could be wrong, and how can you help make the most of this situation?
Well, my first thoughts were, again, there's something must have triggered this if they had been well groomed previously, or again, we want to rule out from the nurse angle. I'm thinking of ruling out anything medical that's going on. Have they taken too much of some medicine? Have they not taken their medicine? Are they having some sort of stroke activity or something that has just not been typical for them? How long have they, I'll try to assess maybe, were they well groomed the last time I was in the home? If I were even a home health aide, this would be something that I would pick up pretty readily. Particularly our home health aides would notice that, they had been grooming themselves pretty well in between visits, and now they're not. So what else is going on? I definitely think that this person would probably need to end up in the emergency room so that we could get a good medical workup. Renee, what are your thoughts?
The only thing I would add to that is I would want to look at the family system in that situation. Has it been the family who has been providing the grooming for this patient? And If they have, then what's happened there? Where has that breakdown occurred?
Right.
If it's not, and the patient has been doing it themselves, then obviously there's some kind of medical issue going on.
Yeah, and of course, mumbling and talking to themselves, if that's new, it's not real clear in this, but if that's a new behavior, then that definitely is triggering that there's something going on that has changed with their mental status, which could be related to some underlying mental condition that we may not have been aware of or may not have been focused on in whatever aspect of care we've been used to providing for them. Or, again, it could be related to a problem with their medication, with them taking their medication appropriately. Ava, again, your thoughts?
The only thing I would add, because y'all were both correct, I mean, to check the medications. And in this case, it was, the medication, they were only supposed to be taking about 8 medicines, and they ended up with like 16 in their bag.
Wow.
They've been picking up older medications and everything and adding to. So absolutely, you're exactly correct.
Well, that's a good point. In home care, of course, that's part of our responsibility as the nurses who go into the home is to review their medications every time we go into the home to be sure that they're taking them appropriately. We encourage the patients and their caregivers to appropriately dispose of medications when they're out of date. Sometimes that's hard because they go to multiple providers and they get a new medicine. They don't want to throw the old medicine away in case the new one's not working. So we really want to encourage those patients to only have the medications that they're taking currently, any old medications to dispose of appropriately. So that would be something that might prevent a scenario like this. I think you have one more for us too.
You're out on a home visit and the family will not let the patient answer questions by themselves. The family is quick to give explanations about the bruises and missing monetary items. What can be wrong and what should you do?
Well, my first thought is there may be some kind of abuse going on here. And again, this would be something that our home care nurses or our home health aides might pick up on. A family member who is acting a little differently, or maybe a new caregiver, a new family member in the home, and all of a sudden these things are appearing. Of course, if I'm the nurse, then I'm going to definitely consider making a referral to DHR. And if I have a medical social worker, a social worker in home care available to me, then I'm definitely going to be calling them. They may already have that as a case, this patient. I'm going to find that out. If I'm a home health aide, of course, I'm going to report that to my supervisor, who would then naturally do a little investigation, very brief, and then go from there.
Right, because what we don't want to do is to leave the patient in a worse condition than what we found them in. And the worst thing we could do would be to jeopardize their health. We don't want to anger the caregiver if we suspect that the caregiver is the one who is abusing or exploiting in this case as well. So we've got to be very careful about how we ask the questions and make sure that we don't ask too many questions. We're not the agency that's obligated to do these investigations. That's not who we are. That's not what we do. That is law enforcement or DHR. So we need to make sure that we get the information to the appropriate agency and let them do the investigation.
So these signs that are in this little scenario certainly point to a potential problem. But again, it is not our job to ask questions that would be intimidating or very direct towards the patient or the caregiver as to anger them or to alert them, so that that way the patient wouldn't be in bigger risk. We don't want to put them at a higher risk. We want to get in there, get out, notice our concerns, report those to the appropriate authorities. And Ava?
I think you're both right on. Anytime that someone's afraid to answer, there is definitely signs of abuse, and they've got bruises, monetary items can be missing. All types of exploitation can be going on, but again, you're right, it's not our job to be the judge on that. So,
and again, older patients have a problem with bruising for the most part. So
blood thinners,
simple bruising is not in and of itself a reason to report. There really needs to be more going on there.
And then
but with what you've got here, it makes sense.
And that dementia patient is going to often think that they've misplaced something that they had.
Absolutely.
But again, I think particularly our nurses, our home health aides, if they're in the home and they're suspecting something different, I think that's what we're agreeing to. This is kind of something new, or we're into a new situation, then we have to look at it and question and certainly report it, because we are mandated to report anything that we suspect as abuse.
Right.
Well, thank you for these scenarios.
Yes,
it gave us
ma'am.
an exercise.
It's fun. Okay, at this point, anything that y'all think needs to be clarified about abusive situations?
Anything from the audience? Okay, I think we can move on.
Groovy. Okay, what can make a normal, healthy person aggressive and unreasonable? Some people redirect anger in specific ways. Some people can just seem born grumpy and angry. However, there is usually something in their life that drives them this way. Those whose anger problems aren't always aggressive, in fact passive. Aggressive people will only show a few people their bad side.
So you're talking about somebody that's passive aggressive.
Yes, ma'am.
Yeah, and that's sometimes more difficult to deal with than somebody's just right in your face.
Straight out aggressive. Yes, ma'am. They can do some little things that tend to really unnerve people sometimes. So yeah. You may know someone that is one of the kindest people around, yet someone else will see just how uncontrollable he or she can be. Not everyone acts the same way with each person. This is because some people redirect their anger in specific ways or towards specific people. Anger may come from genes. It may be psychological. There's evidence that some children are born irritable, touchy, and easily angered. And these signs are presented from a very early age. We all have different personalities. Right.
Wow. That's interesting to know.
And there's some people that's just born happy. You can just tell. Some babies are crankier than others. Yes, ma'am.
Yeah, I just had one question. Hearing you speak from the perspective of the genetic contribution, how do you assess whether or not anger is genetic or whether it's situational?
Well, there's been studies where they go back, and I think it goes back to the parents. If the parents tend to be a little bit grumpy, if there's hereditary, that it's handed down. Some people think, their lives, their jobs, different things can turn you grumpy. It just depends on the person, depends on the family. I'm more of the, studies have shown I'm of the opinion that the surroundings, how you raise the child, is what turns their personality.
So it may be more of a learned behavior.
Absolutely.
Well,
and
and then
watching
on the same token, even if you have a predisposition or a personality towards something, we can learn different behaviors. If we're in a home, say, where it's appropriate for them to scream and yell when they talk to each other, they get out in another setting and then learn that that's not an appropriate way to
Absolutely.
deal. So, combination of both things.
Awesome. Yes, ma'am.
Are there specific interventions that are geared towards anger that's more hereditary? Or is it mainly a family-based intervention?
It is sometimes a family-based intervention, and it's anger management. So a lot of us have anger management classes that we've sent people to. There's trained people that actually specialize in anger management. Sometimes, the younger children, it may be parenting classes that we need to send the parents to, because when a child gets older, they can understand, and absolutely when you get in different situations and different settings, you can learn more appropriate behavior. And teens who get angry may also have a genetic disposition, and they may also just be teenagers, and they may be modeling the behavior from other family members, like you said. And anger can be social-cultural. Anger is often regarded as negative. We're taught ways to express anxiety, depression, or other emotions, but usually not anger. Anger is usually looked at as not being ladylike, not being something accepted. As a result, we don't learn how to handle or channel our anger. And the thing is, we need to convey to our young people and our people in different situations is it's okay to be angry, just do not act out on that anger.
Does that vary from culture to culture?
Sure it does. Sometimes it's not acceptable in other cultures for women to act aggressively or to be very angry. Sometimes, you know, it's taught that it's unacceptable for anyone to yell or to act out. So, you know, that's why we have to really watch when we're dealing with different cultures to be understanding and not to offend anyone.
Well, I think that's quite true of the South, that women in the South are definitely expected, you know, not to be very direct. I know when I've encountered folks from other parts of the country, you know, that they just have maybe a more direct approach.
Absolutely.
Which is not what we're used to always, and that it can be perceived very negatively if you're, if a person is direct.
Absolutely.
So I've definitely have observed that myself.
A lot of times when you're direct, they think you're being bossy or judgmental, and when it's just the fact that you're just being honest and direct. Family background may also play a role in anger. Typically, a person who's easily angered comes from families that are disruptive, chaotic, and not skilled at other means of communication. So that may be the only way they know to communicate is to act out a little bit in anger.
Clinically, how do you define emotional communication?
Well, I would call it any emotional is you're not processing before it comes out. When you get angry and you say the first thing that comes in your mind without buffering a little bit. And that can be when those things that you can't call back.
As my daughter would say, no filter.
No filter. And that's really, I mean, people have sent emails, text messages and stuff. You can't call it back once it goes. So we need to be very careful because any of us can get angry. But we need to be very careful not to act on that anger.
Well, that's another point, is just the way we communicate. We're really talking more about in-person communication for
Absolutely.
this program, but I find that emails and texts and things like that can leave so much open for interpretation because there is not that in-person communication, and we all know that communication is more than just what you're saying. And so when that's left out, when all those other aspects of communication, it's just the words, sometimes they bite without being intended to. So.
And even when our clients are in residential homes or something, sometimes they'll pull up their smartphone or the computer in the break room, and they'll have all this whole thing from Facebook where they've been in an argument with several people. So it's amazing how people can lose their temper. It really is. Some people manipulate when they're angry. They think and behave as if others will change their behavior as a result of their tantrums. And at that time, they have no sense of control, and that's what they're trying to gain by losing their temper.
I've observed that a good bit in other settings with patients who were psych patients. And you know, that was just their way of manipulating, like you said, the situation and trying to gain some sense of control would be by that moodiness, that tantrums, that threats, if you will, of, you know, like what they're going to do. Not necessarily to harm somebody, but just, you know, I'm not going to eat, or I'm not going to drink, or particularly I'm not going to take my medicine.
Absolutely.
That's the big one with those psychiatric patients. So, and often, of course, we're taking care of patients for medical reasons, but they also have a psychiatric diagnosis, or even the caregiver could.
Well, and too, it doesn't have to just be the psychiatric patient. It can be, particularly our older clients, as they've lost so much control of their lives, maybe where they live or even what they're able to eat, what time they go to bed or what time they wake up. They'll control what they can, and sometimes that may be the people around them through tantrums. I've seen tantrums in our older population.
I have too. And when we're dealing with people in residential homes and things, it is. You've got someone coming in and they see it as bossing them around,
Right.
like you said, and they do not enjoy it. So they sometimes have to deal with a roommate that they never had before, and the sharing and being told when to take a bath or maybe when to go to bed, and they're very resentful.
How do you apply that concept when you have staff that are working in shelters and you have people that come in, you do not know that there's a dementia diagnosis, you do not have the family history or the family assessment to give any insight as to why the behavior is the way that it is? How do you handle that type of situation?
That's a good question. You react without reacting, overreacting to certain things. Try to stay as calm as possible. But sometimes you start noticing that they have dementia-like behavior. This happens a lot, especially with disasters. When we have hurricanes and stuff like that, and people are coming into an area, you don't know their background. You don't have their family there with them to speak for them. So if there's medical personnel, they can help you with that. But the thing is not to overreact, to call for assistance when needed. A lot of us are embarrassed to call for assistance, but I think that's the best thing that we can do, is to call for backup, call for an extra set of eyes to assess the situation. And just take things as they come, be calm, and try to clear people away where they're not in any immediate danger, and react with kindness. Thank you. And again, angry people want to give the illusion of being in control, but the person that is angry are not motivating, they're not inspiring, because anger is actually a block. And most angry people are believed to suffer from low self-esteem, but they can also have a medical reason for that. And insecurity is the root of most anger. And they are very much aware of the fact that they are mediocre in a lot of aspects of their lives when they may have been used to living a very different lifestyle. And they try to act like they're in control. An angry person may be trying to hide the truth from themselves. They try to camouflage their insecurities with acting like having tantrums, flare-ups, mood swings, and sulking, not talking to you for a while. An authoritative nature, some people who get angry easily sometimes have a sense of entitlement. What can make a healthy person aggressive and unreasonable? They want to be an authority on any matter that they bring up and do not expect you to counter anything they have to say. If you disagree with them, most of us are in the field, we're like, oh, okay, I value your opinion. They get very resentful. Sometimes they feel they deserve to be attended to, and in not doing so, it angers them.
That makes me think of patients who, as a wound care nurse, I've been in a home and they said, I put Crisco on my wound, and I believe in that. I swear, whatever this is, and and you have to say, yes, ma'am, yes, ma'am. The doctor ordered this for you on your wound, but I've had that where they were just absolutely convinced that some home remedy, which may be inappropriate actually, would be okay. So that can be kind of another aspect of trying to, yes, they're trying to control, but they think that they know what they're doing. And then I've seen that, like you said, get even worse with that dementia patient.
Absolutely.
I think especially when the professional is a younger person.
Yes. Yeah, it did happen when I was younger. But then even the caregiver, have a caregiver or family member come in, or maybe not the one that was always taking care of them, but Aunt Susie or sister whatever who comes in hasn't been there always taking care, and then they get very angry because this worked, and I don't know why this doctor's doing this when that worked, and but I have seen that where they want to be the authority, and they seem to know more than you do, and you may have an expertise, or in our case, following the doctor's orders. in the home.
Absolutely.
How do you address those types of situations when the home remedy is a part of their culture?
That's difficult. You could bring someone in from their culture. That's happened a lot in working with a group that I work with up in Huntsville. They actually have someone that's from the culture that comes in and speaks to the people when they get really offended by something or do not understand. They come in, and that way it's perceived, to be more accepted. And they, but I can understand when it's part of their culture. It's hard. That's hard. It is. But I would bring someone in, a translator or something, and be patient, be reasonable. But we also, like you said, we don't want to offend them.
And it may be that if it's whatever the issue is, if it's a part of their culture and it's not going to be
Harm them.
counterproductive,
Right.
then why not just add our treatment as an adjunct?
Absolutely.
This is in addition to
Partner
what
with.
you're going to do. Yeah, partner the treatments
good.
up.
Yeah, if that's reasonable with a physician, I think that's certainly a good way to deal with that.
Absolutely.
And I really like what you said, Ava, about partnering with someone of that culture, because just saying that the doctor said to do it doesn't always get it. I think
Absolutely.
Again, when I was younger and dealing with an elderly population, that generation, the doctor was God, whatever he said goes. Now we have a much more multicultural community, and within Alabama we have just a number of different cultures who are quite large, part of our patient population. And so getting partnership with that person who can speak, not only literally speak their language, but help them to understand that let's try this perhaps for now because this is what the doctor wanted. If it doesn't work, and give them a time limit. If it doesn't work for wound care 2 weeks, 4 weeks, then you can go back to that. Let's try it for maybe just a time frame might help.
So it sounds like, when we look at the whole concept of establishing collaborative partnerships, but having those partnerships already established and maintained so that when a situation arises where we need them, we can call on them.
Absolutely.
Oh, yeah.
That's one of the community partnerships, MOUs, MOAs can be very handy. You're absolutely right. Okay, anger aggravates anger. Some people have frustrations or problems in their lives which make them react more strongly than others. And pain and discomfort in your life can make you react stronger. Sometimes you can be having a great day, and if you're not in any kind of pain or anything, it could go right by, but the minute you've got a debilitating back problem or something like that, it can seem so much worse.
I know in my personal situation, my father, who's been deceased for many years, but he was absolutely the most delightful person you would ever know. But as his health deteriorated, and he had a lot of pain related to arthritis, his personality really changed. He wasn't a grumpy old man ever, but there were days and there were times where he just wasn't like he usually would deal with issues or things. He really became much more short-tempered, which was not a characteristic of him. So that was a real personal example, but I definitely saw that change in him. When his pain was difficult, he would just have a shorter temper. And that's certainly very likely to happen with many of the patients that we see within the home.
Absolutely. And it's hard on them when they're hurting. They don't know how to manage that. And even sending to pain management or having people to talk to them sometimes doesn't help. And our personal situations plays a major role in the reactions or various circumstances in life. Sometimes if we're having to deal with someone new living with us or being made to accept the role of being kind of a subordinate, it's kind of hard. The reason we get angry is because it's a way of us trying to avoid the emotional pain that we're experiencing. Sometimes it's easier to be angry than admit we're hurting. But the primary reason we get angry is to communicate our thoughts and feelings. And sometimes the patient doesn't know any other way to do it. Some people may suffer from intermediate explosive disorder. And there are people who react to situations with a sudden outburst without thinking or repercussions. This is a little-known disorder marked by episodes of unwanted anger, and is more common than previously thought. It affects as many as 7% of adults in their lifetime.
So I'm assuming by this then that this is not attributed to a stroke or dementia.
No,
this is something that's completely different then.
It is.
With
yes,
no
ma'am.
medical basis?
No, ma'am. And it's really, I mean, it affects someone usually across their whole life.
So would you expect that with assessment of this person that you would find that they had these type of episodes throughout the lifespan, or is it something that typically occurs in teenage years or young adult?
It
or
can start coming out in teenage years, absolutely. Young adult, and sometimes it pares down after that. But 7% of adults in their lifetime, that's a pretty large number.
That is a large number.
Very large.
So, in other words, you know, we do expect teenagers to be emotional, and they're in that process of learning how to handle different situations, hormones, and those things going on. But this would be the person that perhaps, even if there wasn't a situational thing going on, they would just have some type of outburst.
Absolutely.
Interesting.
And that's been diagnosed as intermittent explosive disorder.
Yes, ma'am. IED.
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 So, very good point to make.
Very different IED.
It depends on what arena you're working in, what the acronym means. So,
Absolutely.
Yeah.
And many people diagnosed with this appear to have general problems with anger or other impulse behaviors. And the other impulse behaviors could be shopping too much, spending a whole lot of money that they may or may not have on certain things.
So you might see it with folks that had some of those other disorders, like maybe even somebody that was bipolar.
Absolutely.
Or
Obsessive compulsive.
It goes in with other mental illnesses.
Do you see
absolutely.
this a lot with substance abuse disorders?
You do. Yes, ma'am. And sometimes with substance abuse use, and I'm glad you brought that up, it brings out things that normally were not on the surface. So when a person, again, is using, they're not the same as they were before. So a lot of different things. And also when a person's becoming clean, things start coming out that were not there before.
So that's a good point too. So if it might not be our patient, it could be our caregiver or the family member that brought them into the clinic. It may be someone with that patient who is having these kinds of issues, and then they're the ones that are showing the anger. I would expect that would be something that we might see in a medical needs shelter. It might not be the patient, but the one who was with them, who's experiencing perhaps a withdrawal from some substance, or either they're under the influence of a substance, or this is just the way they behave when they get pressured. And perhaps we haven't encountered that particular caregiver before.
And they may experience racing thoughts, a heightened energy level during the aggressive episode, with fatigue and depression developing shortly afterwards. They may want to sleep for an extended period of time. Some report various physical sensations, including tightness in the chest, tingling sensations, a tremor, or feeling of pressure inside the head.
Well, thank you so much. I think this might be a good place for us to take a short break. And then, so we've talked a lot about what anger might look like, that person who's becoming out of control. Perhaps when we come back, we can talk about, kind of wrap that up a little bit and summarize. And then we're going to talk about how to manage the anger. So we're going to take a 15-minute break, and then we will join the program again. Well, welcome back to our program for today about de-escalating that angered patient. Before we move on to talk about how to manage anger, I'd like to turn it over to Renee for a moment. We wanted to discuss another case scenario. And again, if you have any questions, please send those in either by email or call them in on the 1-800 number. Renee?
Well, I wanted to clarify something that I said earlier about not asking a lot of questions if you suspect that a patient is being abused, because we don't want to jeopardize the investigation. Mm-hmm. But we do need to ask enough questions to know whether or not we really are seeing what it seems to be that we're seeing. I remember a case that I went out on as a young home health social worker. I was sent out there because the caregiver was under a lot of stress and was experiencing a lot of frustration because her mother had Alzheimer's. And when I walked up to the door, I could hear someone banging on the walls or the door or something in the house, screaming, "Let me out." And so my first thought was, I've got to call 911. This woman's locked up in a closet or something. And then the caregiver actually came to the door holding a screwdriver in her hands, like she was going to stab with it. So that was a little unnerving. But after a few minutes of questioning, it became obvious that what had happened is the Alzheimer's patient had locked herself inside her bedroom and couldn't figure out how to get out. And so the caregiver was going to use the screwdriver to take the door handle off. So sometimes things aren't exactly what you think they are. Got to dig into it a little bit. But again, we don't want to ask any questions that would jeopardize a later investigation.
That is pretty dynamic situation you described.
It was.
I could see how you walk upon that and you're like, there's a lady with something that could be, and
somebody knocking,
really misread
screaming,
that.
"Let me out of here," in the back.
Right.
So, yeah.
So that's something where, you've got to know your patient. You've got to have your own confidence so that you ask some appropriate questions and use your assessment skills in discerning what's going on before you react. So that's
and read
a very
the body
good point.
language and the facial expressions of the caregiver. She was very calm. Didn't hesitate at all about asking a social worker into her home, even though there was a lady in the back screaming, "Let me out." So it didn't take but just a couple of questions, and it was obvious what was going on.
And again, that could be the nurse that came upon that. That could be the home health aide who came upon that situation. And so just using your assessment skills, using your cool head, being professional as a home health aide or as professional as a nurse or a social worker, going into that home, just assessing, taking a few moments, deep breath, assess the situation, make sure you're not in danger and the patient's not in any imminent danger. All right. Well, we can go ahead now and talk a little bit. First, I'd like, Ava, for you to summarize for us a little bit on, what does make a normal, healthy person aggressive and unreasonable.
Absolutely. Fear. Fear is a big one. Sometimes they don't understand what's happening to them. Feeling ignored, feeling like people aren't paying attention to them. Being sick, and sometimes very sick and for an extended period of time. Being exhausted, being very, very tired, just overwhelmed, feeling out of control. And just in general, just being very angry and overwhelmed with every situation.
Mm-hmm. So I've heard that HALT, hungry, angry, lonely, and tired.
Never get too hungry, angry, lonely, or tired.
And
Yes,
those are triggers for any of us.
Absolutely.
To lose our cool, to lose our temper, so hungry, angry, lonely, tired, HALT. That's an acronym I've utilized
Absolutely.
and work with clients. And now we can go on to the how we're going to manage this anger. So somebody's really upset. We've got an idea now. We've assessed kind of what's going on. Maybe it is fear-based. Maybe it is related to their medical condition. Maybe we're not sure yet. But what should we do, Ava, to help them manage that anger?
Well, with any problem, we need to come at some way of managing. And anger management reduces both the patient's emotional feelings and the psychological arousal that causes the anger. Getting rid or avoiding the things or people that can enrage the client It's sometimes not possible, nor can they change them, but you can help them learn to control their reactions. You can't take them out of every situation that's going to make them angry. We can't make sometimes sick people feel better. We wish we could, but sometimes it's a chronic illness. So we need to learn to help them manage.
Any ideas that you can share with us related to specifically managing in that medical needs shelter or that emergency situation in a disaster where folks are brought together and obviously there's going to be a very high level of concern?
Absolutely there is. Well, I think as much control as we can allow that person to have over their situation at that time, even if it's small, allowing them to choose something that they can eat, whatever choices we can let them have to let them feel that they're in some sort of control is very important.
I would think listening to perhaps when we're, I know that in the health department that we have a multidisciplinary team so that there are folks that are there to do very specific tasks, but having people who can just listen to them talk about their concern, their loss, their pet that they had to leave behind, whatever, I would think that might help the situation.
Sometimes they want to do that same story over and over and over again.
Yes.
And that's a way of helping them process, actually.
But that's very helpful, isn't it?
It is helpful. It is.
So we may have to have a lot of patience.
We do have to have patience. Yes.
And hear the story more than once.
Absolutely.
And not try to finish that story for them because we've heard it 5 times before.
And try to finish up to something else.
Move on
Absolutely.
with it.
Because that's important to them to get to tell their story. Anger management involves skills through a combination of cognitive structuring, raising endurance levels, and relaxation training. Simple relaxation tools such as deep breathing and relaxation imagery can help calm a person's angry feelings down.
Can you describe that a little bit more? Maybe
A lot
in
of
some
people
different
do,
terms
right.
related to the cognitive restructuring.
Right,
and that
trying
sort
to
of thing.
picture something calm in their mind. A lot of the people, the deep breathing, relaxing, you hear people say count to 10. 10 usually doesn't do it. It's usually breathe in, breathe out, count to 10 again, and maybe a few more times because you're trying to control your anger. And sometimes the anger isn't over just like that.
I've also heard of people using the image of a stop sign. That
Absolutely.
they will let that image remind them to stop allowing this to build up with them.
Absolutely.
And then when they feel it happening, they'll just close their eyes and imagine that red stop sign.
Now, slow, deep breaths. That's always something that I utilize for myself, but I used to teach patients in various settings, and just to calm and take that cleansing breath really slow and deep and try to get them to do it about 3 times if I can engage them to where they can follow that command. I found that sometimes helps, and even a little very simple technique, you may know a lot more about it than I do, but someone showed me where you drop the chin to the chest and do that deep breathing, and it just produces a physiologic relaxation response just by dropping the chin to the chest. It just kind of enhances that relaxation breathing.
And I think also learning to recognize triggers.
Yes.
We talk to people in the addiction field all the time to recognize your triggers, what's going to make you want to use. If a person has an anger problem, know what's going to make you angry and try to avoid those triggers or be ready when they happen. So I think that's important. And cognitive restructuring is actually changing the way a person thinks. It's a way of calming the patient, reminding the patient that getting angry is not going to fix anything, and it won't make you feel any better. You hear people all the time, go ahead and vent, and it'll make you feel, it doesn't. It gets your blood pressure up. You end up hurting people's feelings. You end up being embarrassed after you lose your temper.
So what I hear you saying is that it might be a good idea, we were talking about letting them talk about their loss, but perhaps we need to guide them to say talk about something maybe more positive or something that they could relate to that would help them to deal with that anger, like you said, the imagery of the stop sign, or for me it would be imagining myself on the beach with the wind blowing in my hair, that kind of thing. For someone else it might be something quite different.
And even just saying, what's something positive you got out of that situation? What would you do differently if you could go back? It's a way of letting them stop and think a little bit.
So what did you learn from that situation where someone had done something to you and they're telling you about that and they're becoming angry? You could stop them and say, so what did you learn from that, or what have you gained from that?
Absolutely.
Okay. Try to help them to see the good side of a bad thing, perhaps.
That would be awesome. Yes.
Okay.
Keep your interactions with a person when they're really angry as short as possible. And minimizing your exposure. And it goes a long, long way. We don't want to keep ourselves, because sometimes when they're very angry and we keep interacting, it keeps drawing it out. So that doesn't help. And keep it logical. If a person's very verbal, lighthearted, focus on that person. Always try to connect with them and reason with these types from the emotional or empathetic perspective. And you know those who say when you do X, it will make you feel Y. Communication tactics were taught in relationship books. Sometimes that makes a person angry. Sometimes telling them, okay, if you do this, it's going to make you feel like this. It may not make them feel like that. They may have a different reaction.
So giving them a canned answer sometimes is not going to be the best thing to do.
No, we need to focus in and individualize, like we do with our treatment plans and everything else. We need to individualize with that client or patient. And the type of heart-centered communication only works for reasonable people. If a person's very upset and not reasonable at that moment, it may not be the best thing to do.
So the IED, who is in the middle of the
Having a
the
rage.
explosive,
Right.
That's not the time to do that.
It's not a time to be communicating with our heart and trying, let's examine this feelings right now. Sometimes giving a person a little bit of space is really a good thing.
So if they're just really angry and you can get yourself or the others away from that, then letting them spout it off, yell, whatever. If you can't approach them, that just might be the best way.
Thing to do. Yes, ma'am.
And then you said earlier something about showing having kind of a group of people to confront them.
That can be just like any other confrontation. I noticed, if we're doing a confrontation about drug use, I noticed that you've been drinking too much lately. It could be a confrontation about anger. Lately you've been acting angry with a lot of people. This is how this made me feel. So sometimes that helps. Not with every person, but sometimes it helps.
So that person that's in the medical needs shelter or some shelter that we're managing, and they're getting loud and they're getting disruptive and they're expressing this anger, help us with what we would do.
They're getting loud, and usually there's other people around. So we want to get them contained as much as possible, whether it's taking them outside away from others, because we don't want other people upset or other people joining in, because if they're talking about, well, I lost this, other people may become upset, well, I lost this also. So we need to get them away, get them by themselves as much as possible as we can.
So that person who's really acting out and loud and just disruptive can perhaps, especially in a shelter situation, can actually upset
others.
Yes.
Absolutely.
Yeah.
They can, and because they're having similar experiences. So if they're upset and they're, well, you know what, I've lost that too. I'm not griping, or they could start reminiscing on what they've lost. It could be more traumatic. Keep communications as much as possible fact-based and only use minimal details. Don't let your emotions play into it because sometimes they can make you angry. And we are caregivers, but we don't need to do that.
That minimal details, I think that might be something to expound upon as well, so that you might have to repeat yourself.
Absolutely.
In a situation. You know, the meals will be delivered at such a time, and just whatever the plan is, just reiterate that.
Absolutely.
For example. That's what I'm thinking, so that you don't go into all these details of, well, I've called the supervisor and it's on the way and it's this and it's that. Just
what they need to know.
I
think that's the thing. Say what is absolutely necessary to know, and don't expand on it, because I mean, it doesn't. Anything that's not necessary for them, really, we don't need to bring up.
Well, I would think it would be hard for them to remember several details if they're in the middle of a rage.
Absolutely.
Then you really have one message, whatever that one sentence may be, and just we need to get that out there.
Absolutely.
Nothing else.
And perhaps in another setting, I'm thinking in terms of home care, if you're out there in the home and the family member is becoming escalated and angry about something, I'm thinking in terms of just what you said, but redirecting that, you know, this is what the doctor ordered, this is what, you know, I have come here to provide for your parent. If this is a problem, then, you know, we need to discuss it with the doctor. Is that okay? But keeping it very minimum and their options to a minimum. And then, you know, anyone has the right to refuse care, of course.
Absolutely.
We have to remember that. And then we could back out of a situation like we said earlier, and if it's a situation that we need to call our supervisor about or whatever, but we want to make sure that you're safe, patients are safe, and the people around you, whether it's in the home setting or in a clinic or in a shelter, everybody is safe.
Absolutely.
How does that apply when you're dealing with someone that has autism?
Sometimes that's very difficult. But again, we stay as calm as we can. We try to keep distractions away from that person. And again, remain as calm as possible. Keep them away from, you know, as much as possible, minimize and keep them away from other people at that moment to try to calm them. Keep the noises as low as possible. And react very calmly ourselves. If our voice raises, it's going to escalate to another level.
Relating that to the communication issue, when you talk about using as minimal of details as possible, I'm asking from the standpoint of being general versus being more concrete and specific, because there are some people that do need those specific details in order to be able to function.
Okay. Well, then we can always adjust when the time comes, if we see that's necessary. A lot of times with autistic, you know, to communicate on the computer screen is better than actually verbalizing and talking, because the person may or may not be verbal. Moving very fast or something can upset someone. So to say that, you know, just be generally, where you say something, you know, and don't give too much information, that's just to try to get people through it as quickly and as easily as possible. Because in a situation like that, everybody's panicking. I think the caregiver would be overwhelmed. I can see everyone being overwhelmed. So the thing is at that time to have as much structure as possible.
So it sounds like when we're looking at plans as it relates to disasters and emergency preparedness, we need to consider other resources of communication.
Absolutely.
In addition to just the face-to-face verbal. So having a computer to communicate with someone by, as well as other.
And sometimes the situation's not ideal. Sometimes we don't have all those things.
Right.
Sometimes we may not have electricity, but, you know, hopefully most of the time we will. So, and some people specialize in that area. And if you're blessed to have a person in your agency that does specialize, that's awesome. If not, you know, we treat everyone as kindly, and usually there's a if there can be a caregiver or someone there, that would be wonderful. Thank you. Okay, a way to avoid being the target of demanding comments, manipulation, or having your words twisted is to say as little as possible. Because some people, when they're angry or just looking for you to say something, they're going to twist it on you. Mm-hmm. And it doesn't make anything any easier, because at that time they're not being rational.
Mm-hmm. Yeah, I think in terms of having patience in asking the same question over and over and over again, mm-hmm. and whatever it is, like, you know, why don't I have so-and-so, whatever it is, my mm-hmm. DME equipment or whatever. Certainly we may be working on that, but rather than, like you said, just keeping it to a minimum and not making excuses for
Absolutely.
anything as to why whatever the situation is the way it is, just stating the fact calmly and succinctly, so that, you know, like you said, they'll ask you 10 times, but you've got to answer it the same way.
Absolutely.
Basically.
We have a question.
Groovy.
You're ready to take a question.
Okay.
In the home care setting, when you're dealing with an angry person, at what mm-hmm. point is it okay to contact law enforcement, for example?
I think when you feel threatened. Anytime that you're in immediate threat, either party is in immediate threat of physical danger, is when you would call.
But I would think, too, we'd want you to get to a safe place.
Absolutely.
You don't want to stand there and, I'm calling 911 on you right now. You
right.
don't want to do that.
And that will
you would
escalate.
want to get
right.
to your car, and maybe go down the block, whatever. Leave the location, if at all possible, if you're in the home.
Absolutely.
Because you don't want to be there when you're calling. Mm-hmm.
And that would only make the situation worse.
Yeah.
And they would be very
mm-hmm.
upset. That's a good question. Sometimes giving up the dream that a person's going to change radically in their behavior, the way that you wish that they would change, is something we have to give up. When we're coaching clients, this is something we see all the time, and we want them to be a certain way or a certain societal normal that we think, but sometimes it's not going to happen. Mm-hmm. Sometimes they can make improvements, but not what other people think that they should.
Mm-hmm. I can see this. I've seen this in the mental health patients that I've worked with, and where you would have hope, but then, you know, the ones that are not going to take their medicine mm-hmm. usually don't take their medicine.
Absolutely.
And then the same thing with some folks with certain illnesses. I have seen over the years just some generalizations related to folks with certain disease processes that almost have a characteristic that goes with that disease process, mm-hmm. Because perhaps it's a difficult one to deal with. It relates to some lifestyle changes that people are just not real comfortable in making, and you start seeing kind of a norm that develops. If they're going to take care of themselves and make changes, they usually do early on, and that is not typically the chronic patient that we see in the home care setting, you know, that has some sort of chronic problem, mm-hmm. and if they would just do X, Y, Z, then that chronic problem would be managed better, but it flares up every week or every month because they're not, and that can become very frustrating for us as the healthcare providers as well.
There are people in our lives who have moments where they seem to be the parent, partner, and spouse, and friend that they used to be. Sometimes they can go back, but you always felt it could be, yet ultimately always end up hurting or disappointing us sometimes when they go back to their disease. Sometimes when someone has Alzheimer's and dementia, they have moments of clarity where your mother may know you or your father may know you and know your name. Then all of a sudden when they go back, it's very disappointing and very painful. It's painful for people when they have to become the role of the caregiver instead of the role of the child, the niece, nephew, grandchild. It's also very hard for the patient, very hard. When they have those moments of clarity and know they're being taken care of, that they don't have control, it's very, very hard for them.
And I know I've often told the caregivers that we have to go to their world, to the patient's world, because they can't come to our world.
Mm-hmm.
And that's not always easy, especially if they happen to be in an angry place at the moment. So, but just know that it's the disease and not the person choosing to be that way.
Absolutely. And sometimes this says fall forth. That's not quite the words we need to use. We get our hopes up, and the next time they treat us in a certain way, and they go back to the same way they used to be. Sometimes we need to learn to accept people the way they are. To understand mom or dad does have a disease. They do have dementia. And some of the times that's hard for us to understand. It's hard. I've been in that situation. It was hard for me to accept.
Mm-hmm.
So I can totally understand. We want things to be better.
Mm-hmm. I think those of us in the healthcare arena, we want to. I've noticed with my own, again, my parents have both been deceased for a number of years, but in my work situation, dealing with them, and then dealing with coworkers, friends, and other folks that are dealing with their aging parents in different scenarios, it didn't matter how much education any of us had, that was our parent, that was our child. And so some of those things kind of go out the window. So if you're dealing with a patient or a family member, regardless of the setting, it really doesn't, I've found, it really doesn't matter what that education level is a lot of times, because it does become very difficult to accept that daddy is not daddy anymore, that he is not able to do X, Y, Z for himself. He might be today, but tomorrow he's not, so he's not going to be consistent, in that he may be on some sort of progression towards more and more dependence. So I, as a family member or caregiver, are going to have to make some decisions. And I find that to be kind of universal. Again, that it doesn't matter, of course, if you've got economic resources, that can be a little different scenario, but I've found that emotionally it's not any different. And accepting that loved one, that patient, is not going to get better is just as difficult, regardless of across socioeconomic, educational backgrounds. It's just as difficult,
Yes.
Regardless. So we're all sort of on that same level field with one another when it comes
Absolutely.
to that. And being angry or upset because mom is not going to do different, or she can't do different, is the reaction can be from anyone. That can be kind of difficult.
And how do you handle a situation where family members are looking at this in different ways? You know, one may want to argue with the patient and try to explain where the patient's wrong, and another wants to accept it as the disease process. How do you balance that between those two family members?
I think there needs to be open communication, and that happens a lot. I mean, it does. That happens a lot. So absolutely, the open communication, and it is part of the disease, and to argue with a person is not going to help. So, but you know, that's that person clinging on to the person they used to know, so I can certainly understand that and certainly sympathize. Okay, stay away from topics that can get you into trouble. Before going into an intervention with a difficult person, review in your mind the topics that invite attack and be proactive about avoiding them. Don't bring up anything that you know that they're very sensitive about, that's going to cause them to get very upset and to want to argue with you. For example, if your in-laws are always making cracks about your choice of a career, answer in a neutral way and change the subject immediately. If they ask you how your work's going, just try to keep it neutral. Don't try to get in an argument with them, because it could easily escalate. We don't want to do that. Don't try to get...
So talk about the weather is what you're kind of saying, as we would say, quote unquote. Change the subject to something that's more neutral.
Absolutely.
Rather than the one that gets you fired up or would get them fired up.
Absolutely.
If you have that
opportunity,
knowledge.
right. And don't try to get people to see your point of view. We're not going to win at that moment. Don't try to explain yourself or try to get them to understand and empathize with your perspective. They won't, and you'll end up feeling worse for trying. Try to create a distraction. If you absolutely have to spend time with someone who typically upsets you, try to be around them in circumstances that offer some sort of distraction. Movies. A game or something would be really good, unless you're on opposing teams. But it's something that...
That's a good point. In Alabama, they can avoid the relatives or friends, no matter who they are, if you're on opposite poles of the fence on football. We know that.
Or just have something that's a distraction for you to do that you're not focused in on, like, why did you choose to do that kind of work, or why are you doing this? It'd make the day go a lot better.
So, like if you're a movie, or like you said, outside, or it might be appropriate to go to the family gathering if there's a lot of other people there. So
Absolutely.
There can be
be a buffer. Yeah.
Something to buffer the situation.
Yes.
These are techniques that not only we could use, but we could share with our clients.
Absolutely. If they have a pet, focus in on that pet, playing with the dog. Have the interaction be based around some kind of recreational activity or entertainment, like we said. Or offer to help in a way that takes you out of the main ring of the collision. If there's a dinner, if you want to go chop vegetables, or offer to wash dishes, or something like that to take you out of the main conversation.
So that you're not sitting alone in the room with the person that you can't stand to be around.
Absolutely.
For 5 minutes.
Yes, ma'am. That's it.
Okay.
And if you can get them to do something that takes their mind off the situation, taking it off you would be even better.
So you could send them to the kitchen to do the cutting of the potatoes or the carrots or whatever.
Or to find some different ingredients or something like that.
Okay.
And if you master the skills to conduct these interactions while being civil and even friendly, you can even save a relationship or save the relationship that's involved. Because if you're dealing with in-laws, it hurts your spouse when you have problems with the in-laws. Or if you have a problem with a brother or sister, it hurts other siblings. So if we can do that, it saves other relationships. Not that you would necessarily want to, but in some cases, if the person is a family member, boss, or other kind of key fixture in your life that you cannot absolutely cut out of your life, these tactics may, in fact, be a lifesaver to how to manage your time around them. Because you can't put some people out of our lives. We can't choose our family.
All right. So these are some great ideas. Like I said, not only for us, but for our clients, so that it's okay that they limit their time, perhaps, around a family member, rather than cutting them off altogether, but limit their time in such a way that they use some of these techniques, and then they're not feeling as trapped. That may help them to deal, as you said, with their anger, so they don't feel trapped in a situation that they just can't get out of.
Awesome. Okay, physical placement to minimize aggression. Speak calmly in a reassuring voice. We don't want our voice to raise, and sometimes that's not as easy as it sounds when we're feeling upset ourselves. But keep your voice calm. Have your palms up with a gesture and your hands not moving on your side, kind of to your side.
So you don't want to be like this.
You don't want to have anything moving towards them because that makes them feel threatened. Back up to give the patient some room when they move towards you. We're not trying to show any kind of dominance. We're going to back up and let them have all the room they want. Know when to run. I'm not ashamed to run. I'll run at any point. Remember, you never want to physically harm a client or a patient or a family member. We don't want to get in a wrestling match, ever.
I like that, too. Know when to run. I think that is a very key point to make with our home care staff. We hope that you don't get in a situation where you have to run, but you can apply that, know when to get out of that situation. Be watching for the cues that we've talked about. This is if you go into a situation where it's not like it usually is, or you already know there's drug abuse in the home, perhaps by a family member and grandmother is in the back room, but be aware of what's going on. If there's an argument going on in the front room, know the way that you can get out of that house safely and quickly. If you need to then call 911, certainly. But I can see that could happen with our home health aides easily, or our nurses in the home. In the clinic, that might look like what, Renee, would you think? I would think know when to call for backup.
Right. Anyone who is becoming angry for whatever reason. I think about maybe our DIS people who are telling individuals that they have a disease, particularly a sexually transmitted disease, and they know they've been faithful. So that can become a very, very intense situation.
So we need to be really very aware of what's going on, whatever setting we're in, whether it's a home or whether it's a clinic or whether it's the shelter. I would think shelter brings a whole nother aspect to it, because everybody's heightened awareness, and you're worried about your family at home and what the hurricane is doing or whatever the situation is. But we need to be very aware of what's going on around us in case one of our colleagues is experiencing or with a patient or a family member that is escalating, so that if we hear that person getting loud in the other exam room or in the hall, that perhaps we need to we're not in an acute situation like in some of the places where I work, where we already have a team planned to do that and do an intervention, but you might want to think about what would you do in your clinic. If you hear something going on that sounds like it's getting out of hand, go and see, is there anything I can do? To try to, sometimes that other person coming into the situation who acts very benign, they're not the person who just told them the bad news related to their STD, but maybe it's someone else who can say, can I help you, and kind of diffuse the situation. So I think it is really important that we think of this and kind of plan ahead as a team of what would we do and how would we manage, how would we help one another with a patient or a client or the caregiver if things start kind of getting out of hand.
And that's exactly one of the questions that we just received. It said, what would each of you say is your best example of a tense situation that you had to de-escalate with a patient, and what did you learn from that experience?
Well, with me, it was a personal experience. It was my father when he was dying, actually. He he was delusional at the time, and he thought that I was his mother. Was very angry with me, was very not wanting to do anything that I suggested. So having a caregiver to come in, and he would focus on them and talk about his mother, and it was a chance for me to kind of move to the side and slip away, and that kind of de-escalated the situation because I was very hurt. He was very frustrated. So it was a chance to kind of de-escalate for both of us.
Renee?
Well, mine is a little bit comical, but it wasn't to the patient. It was an elderly woman who had been widowed for about 10 years, and when I went into her home, as I sat down, she had always been very, very calm and very nice and sweet. And when I sat down in the chair beside her, she pointed her finger at me and she said, "Get off his lap, you hussy." Well, she thought I was sitting in her husband's lap, and so I had to immediately jump up and move in a apologized to him for my poor eyesight, that I had not seen him sitting there. And I remember he'd been dead 10 years. But anyway, I went to her world because she wasn't coming to mine. And, but just, I made it be my fault. I mean, obviously it was my problem. I didn't see him there.
So you didn't argue with her?
I did not argue with her,
to say, no, your husband's been dead 10 years. And
I'm not a hussy. No, I didn't argue with her.
I have a couple of examples. One was comical in a way. My mother, before she passed away, she had had some strokes, finally had a big stroke, so it altered her mental status, similar to a person in Alzheimer's, but was kind of stuck at that level. Well, she was a smoker, and I remember I was about 5 months pregnant at the time, but I had hidden the cigarettes. And I promise y'all, I had been very clever, and I pretended to go to one room and went to the other, and anyway, but she found the cigarettes. But what was funny is she was able to get the cigarette in her mouth and had it turned backwards trying to light it. And so, I mean, it was so funny. And then she's kicking at me. Now I'm pregnant, and of course I made sure I didn't get too close. But it was really comical because, of course, my mother would have never, ever done that. It kind of spoke to me on two levels. One, the power of the addiction of nicotine. It is a drug, and I'll leave it at that. And then the other thing, though, was the fact that her mental status was altered, and that she really didn't know what she was doing. But she was clever enough to watch and figure out where we hid the cigarettes. So we finally had to get them completely out of the house. It just wasn't, because I mean, I didn't mind that I was going to light the cigarette for her at that point in time. With that nicotine addiction, it's not worth trying not to let them smoke at a certain point. But, I didn't want her to burn up the house or have anything like that. In the other cases, so that one, I just physically distanced myself because I knew she couldn't get up and really hit me or hurt me. So it was just kind of funny. But in other situations, it's been quite more serious, and I was dealing with people who had hurt folks and even hurt themselves, by hitting the wall until they broke their hands and things like that. So people who could really, really hurt somebody in another setting. But in those cases, we have a show of force. We did some of the techniques that you've talked about, where we try to talk very calmly, rationally, slow, have one person to speak when you've got a group. And sometimes you do need that backup, but we found it important to have one person. It may be that you have to talk through that scenario before it happens, or kind of make eye contact, like if it was us and I'd say, Renee, this is your patient, or this is someone you know, and then Renee would be the one that spoke to the patient rather than all three of us trying to talk to them at one time, which could be very confusing and hard and would escalate their anger.
Or just whoever is the first person to speak takes the lead.
The first person that takes the lead, yeah, the first person to speak. Whatever kind of little method that you can work out seems to work better. Have that one person, even if you have to have a show of force, giving them some physical room. Like you said, backing off, doing anything so that you're not making any real threatening. That's not the time that you really want to make a lot of eye contact. For example, even you want to be direct, but you don't want to do anything that could be perceived as a threat with your body language. I find it, when I get excited, I do get louder. So I have to think that I need to speak slow, I need to speak quieter. Because my adrenaline may be up because I'm a little bit afraid in that situation. And so just like you said, slowing those things down, I found that helped. And just sometimes having more than one person there it can work against you, but quite often when you get 2 or 3 people standing there and you've got one person speaking to them, they will a lot of times back down from their aggression of threatening you if they're actually into that mode of trying to make a threat.
And also, I would think making a conscious effort not to invade their personal space, their personal bubble. And always make sure you stay at least arm's length away.
Absolutely.
Just in case that fist were to swing.
However far you need to be at arm's length. I can think of my children when I used to have to say that. He hit me. Well, you know what? If you weren't that close to him, it couldn't have happened. So, and then I see there you've got remembering that you never want to be physically harmed, and you certainly don't want that to happen with a patient.
Absolutely. We never want it to get to that point. And it's better to turn away, walk away, or move out of the way than to let anything physically happen. A mind altered by a substance is not rational. So sometimes when someone is under a substance, even if it's a prescription drug they're not taking appropriately, it can change a person's behavior.
That's a really good point. The scenario, one of the scenarios we talked about earlier was just that. They were not taking their medication appropriately, so their mind was altered, and they responded differently, and it could create a situation that could be very dangerous for the patient, the caregiver, or even the worker.
And that's why they call it under the influence. Sometimes when we do things like that, we would never do something like that any other time.
And I have found that if folks who are addicted to nicotine, if they don't get their cigarettes,
Oh my.
I'm going to tell you what, I'm serious. I could give you 5 examples off the top of my head, but where it was just a matter of not getting their nicotine, and they were so irate, both personal as well as professional situations, and you would just really be surprised. And I've worked with drug addiction. It was more serious drugs, controlled drugs, but the reaction would be the same. It's kind of startling, but nicotine does have that effect. If you're addicted to it, folks are very irritable and very angry when they are not able to utilize the nicotine. I think we have a couple more questions.
No, that was it.
I did have one question I wanted to ask. Going back to that, next to the last slide, the last bullet point, what are the legal or ethical considerations when you have a patient in a non-traditional setting that does escalate and they become physically aggressive? Okay, where do you draw the line between their physical aggression and the provider's self-defense?
Well, the way I've been trained is we never get physical with any client, ever. That's the way I was trained. Other places have trained differently, and I'm sure there's a way of de-escalating and taking someone down using restraints. Places I've worked, we've never restrained. So people can be abusive, but I'm very fearful when it comes to grabbing or touching someone if I'm afraid of hurting someone. So I would never.
In your settings, if you would just expound a little bit more about the type of setting that you're speaking of.
The settings I've been in is like IOP class, which is intensive outpatient, residential with substance abuse. There was never any case. I mean, people get irate, they get angry, but you're not having to wrestle anybody around. I would not feel comfortable doing that. With some cases of people having conflicts with substance abuse, you know, sometimes different drugs can make us very angry. Stimulants can make someone act in a way that they normally would not. We've seen meth change a person's attitude or what they would do as opposed to other kind of drugs that are not stimulants. Alcohol can let someone's inhibitions go way down to where they would act in a way that they normally would never, ever consider doing. But in what you're asking, a lot of people do the self-defense where you're just getting away without touching, and that's what I've always been experienced with. Other places have been trained in SOMA, which is actually being allowed to take a person down or whatever. I've not been trained in SOMA.
And then there's something that's pretty popular across the nation. It's called CPI, crisis prevention, the techniques. and those are utilized in some of the more acute settings. And then again, as you said in your question related to legal, it depends on the setting that you're in as to what is required by law and what you are able to do as far as putting your hands on somebody in an acute setting, in a psychiatric, for example, or mental facility. Most of those are trained, depending on what type of facility it is, either to de-escalate the situation at all cost verbally, and like with all the techniques that we've talked about today, at last resort, hands-on. But hands-on are only to secure that patient so that they are not a harm to themselves or others. And any time that there is any restraint situation, even if it is just a matter of this with a patient, of course, that requires follow-up with assessing them, calling the physician, calling the family. If they are ever in like 4-point restraints, in most cases, this will apply different from one institution to the other, so you have to follow whatever that institution says. But those things are very, 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 very limited, and the patient is observed very closely, one-on-one, the entire time. It's considered restraint even when you have a one-on-one situation with a patient. Say that you're watching that patient and you're allowing them to move around their room freely, but that's still considered restraint if they're not able to leave their room completely freely without, you know, someone being with them. So there's different levels with the depending on the setting. If it's institutional, that can be quite different. In an IOP setting, which is an outpatient, or in drug rehab, they are not required to be there. They are not committed to be there. It is all, they may be court ordered to go there, but they are still there voluntarily. So if they want to walk out, if it gets to that, you can do hands-off. If you're in a different setting where they're committed mentally, then that has different rules and different sets of things. With our patients in home care, what we want you to think about is to be very aware that people get angry. We all get angry. Sometimes we don't handle our anger well. Patients who have dementia certainly may not handle change and anger well, and so we'll have to adjust to that situation. We want to make sure that we are aware of our caregivers. If it's somebody we're not familiar with, who are they, what do we know about them, so that we're not caught in a situation in any way where we, any of our workers in the home particularly, are in any harm's way. In the clinic, what I would like to challenge you to do is to be prepared to talk about this subject. Think about what you would do as a response in a situation like this, as well as in the medical needs shelter. I would hope that I'm certain that's part of your training, and maybe that'll be some things that you can think about more and get with the folks that you're working with as a team, so that when these situations arise, I'm sure those of you who worked in the shelters, everybody's more heightened. And so you're more likely to encounter one of these situations, I would think, on a regular basis. So how would you handle that? And Elena?
And most shelters do have some form of security, so it may be appropriate to call for that security. It may be appropriate to call for local law enforcement.
I know we're about to wrap up, but one last question I did want to ask. Because we do have a range of different viewers who are tuning in to this program, in addition to public health providers, as well as people from other state agencies, community organizations, as well as faith-based groups, what additional resources can you share that people can access or follow up with to learn more about patient or client de-escalation?
Absolutely. I think there's a lot of anger management classes. Your Family Success Centers always offer those at a very either free or nominal cost to the community. We refer a lot to anger management. With counseling, we're referred to anger management. Learning techniques ourselves. There's a lot of wonderful books out there, a lot of wonderful advice. I would tell anyone not to make things worse. When you're in doubt, don't try to put your hands or anything on someone, because that can make things worse. So absolutely to refer them to your local community centers, your local hospitals has a list of different resources. Your local mental health center has a list of different resources, and those are there for you. Your local community mental health center. You can call and find out a list of different support groups, and not only about this, but all kinds of different subjects.
And there are a lot of techniques out there. I'm not promoting one over the other. I'm just more familiar with the one that's called CPI. You can Google that. You can Google up de-escalation and techniques and find one that that might be more appropriate for your particular venue, your agency, your institution, wherever you're working. If you don't have some sort of plan, I would encourage you to do so, because I think this is something that we will continue to encounter and perhaps even encounter more often.
We have one last question. We've talked about UTIs and being dehydrated,
Absolutely.
but what other medical conditions could cause a person to become angry or confused?
Well, being dehydrated, anything that takes your senses away. I mean, severe high blood pressure. One time I was with my mother at the hospital, and they said because her blood pressure was so high and that they could not get anything regulated, she actually lost control. So any kind of medical.
Blood sugar. Blood sugar is another one. I've noticed that with patients as well as with
you don't
family
have to be
members.
elderly for blood sugar.
That just a short temper, their anger just flares quicker. If that blood sugar, that's a sign really that their blood sugar is either too low or getting too high. They're just not feeling good, and so they're reacting that way. Pain, like I said, chronic pain, anything that causes chronic pain. That is, even if they're not under the medication, they can be, if they've got chronic pain and then they're taking, say, they're having to take Lortabs and they run out of them, they take them up too soon and they can't get them, so it could be that they're in pain, but it also could be that their medication is either run out or it's not effective. Or they're in some type of even withdrawal from that medication, even though it may be prescribed. So that would be another case.
Awesome. And just going back to the CPI and the SOMA trainings and stuff like that, I would encourage everyone to get with your company's policy and procedures.
Yes.
And know that we're on the same page as our company, because we wouldn't want to do anything that our company would not stand behind us.
Absolutely. First and foremost, and if those of you are watching from other states, we always defer not only to your agency's policies, but any particular state laws in your state that might be applicable under this topic.
Absolutely.
Well, I think we're about out of time. I thank you so much for attending this program. We have other programs that will be coming up, and you can look at those on our website. Thank you again for joining us for this afternoon, for this very lively discussion. And thank you, Eva, and thank you, Renee.
Thank you.